Hi, I'm Bern Sargis, president of Oklahoma State University, and we're here for another episode of Inside OSU, this time at the Center for Health Systems Innovation in downtown Tulsa. And with me today is Dr. William Paiva, who is the director of this very innovative place.
Yeah, welcome. Thank you. Happy to be here. No, I'm excited.
We're glad you're here. Let's find out a little bit about you, first of all. Tell us a little bit about your background.
Yeah, I started my career out actually as a PhD molecular biologist, and originally was going to go down the path of being an academic scientist. And I decided to go to business school so I could get on the business side of science. And prior to running the Center for Health Systems Innovation for literally 20 years, I worked in healthcare finance, innovation, entrepreneurship.
This center was really the brainchild of the dearly departed Neil Patterson.
Obviously, and Neil is a great story for Oklahoma, for Oklahoma State. I can tell you as a venture capitalist, it is extremely rare that somebody is the founding CEO of a company and grows it over 30 to 40 years into a company with 27,000 employees worldwide.
Yeah, Cerner Corporation.
Yeah, Cerner Corporation.
He, of course, was into innovation himself at Cerner.
Oh, sure.
But I know that he wanted to see this started, and he actually seeded it with more than money, didn't he?
Yeah, so we were really lucky. Neil not only provided our foundational financial resources to get started, but he donated a data set to us from Cerner Corporation that has clinical information on 63 million patients. Now think about that, 63 million patients. It covers the entire United States. And if that isn't good enough, it covers 16 years. So I can go back in time and look at how patients progress and be able to then make predictions of how patients in the future will respond.
Now these are de-identified records, so there's no names on them.
That's correct. By the time it comes to us, we're blessed because it's de-identified, HIPAA compliant, so we don't ever have to worry about patient confidential information, and we can go right into the data and start doing the work that we want to do.
Now how does the center intersect with OSU's goals of, for example, rural health and the like?
Yeah, what's unique about the center is actually the center sits between the business school and the medical school. So, and that was done purposely, because what we really wanted to focus on was kind of the business of healthcare, if you will, because we tend to do a very good job clinically in the United States on the delivery of healthcare, where sometimes we have some of our major challenges is really at that business of healthcare. And so what the center really focuses on is at the intersection of business and healthcare. But within that, we've charted a course to transform rural and Native American health. And why do we pick that niche?
Have you done that?
Yeah, and let me tell you why we picked that niche. Because I know as a venture capitalist for 20 years, everybody's focused on urban innovation, right? So we're going to innovate in Dallas, and we're going to innovate in Tulsa and Oklahoma City and Atlanta, because that's where the money is. It's why Willie Sutton robbed banks, right? It's the Willie Sutton rule.
Yeah.
But so often rural can get overlooked, which is unfortunate, because 20% of the U.S. population lives in rural America.
Without adequate health care.
Without adequate health care. We talk about health disparities all the time. One of the biggest health disparities out there is 20% of our population in America is living in rural markets with inadequate health care. And so what we decided to do was to focus at rural health care specifically, because it aligned, not only is there a big unmet need, as I've already articulated, but it aligns with OSU's land grant status. It aligns with the Center for Health Sciences focus on how do we actually graduate and place healthcare professionals in rural markets to improve rural healthcare. For all those things, we decided to complement the existing efforts we're doing in all things rural at Oklahoma State by adding the innovation components to rural healthcare.
Talk about the elements that have emerged here at the center over the last few years.
Yeah, absolutely. So we actually do two things within rural health innovation. So what we try to do is first look at how is healthcare actually being delivered in a rural marketplace, really from the business perspective? And how do we actually knock down those major impediments? Because fundamentally, we can continue to graduate more and more professionals and place them in rural healthcare, and we're doing a great job of that. But we also need to look at what are the workflow inefficiencies, and how do we take those inefficiencies out, wring those out so that our providers out there can do more with less, basically.
Well, and you don't have, in many of the rural areas, you don't have the specialists that you need for certain
Absolutely.
procedures.
Yeah, so not only do you have an inadequate primary care coverage, but you also lack the specialist. And so one half of our center focuses specifically on how do we actually identify those major impediments, innovate around them, implement them in the field, and actually show real results.
Can you give an example of?
Oh, no question, absolutely. So when we first started this center out, I used to have a saying as a venture capitalist that entrepreneurs have a great ability to discover solutions for problems that don't exist. And I was like, we're not going to do that at the Innovation Center. So we're first going to go out there and say, what are the major challenges in Oklahoma for our rural providers? So we went out and did a comprehensive survey of our rural providers. And we basically asked them, what are their major impediments to delivery of effective care in the rural markets? One of the examples of one that popped to the top is everything related to scheduling, logistics, and transportation. Quite honestly, just getting patients to the appointments. Because if the patient doesn't make their primary care visit, usually they get sick and they end up in an emergency room, and that's cost to the system. If I'm running the business and I'm a doctor running a clinic, well, that missing appointment that didn't show up could be $90 to $100 of lost income. So there's a big issue related to the business of clinics of getting patients to show up. It impacts the payers, it impacts the patient, it impacts the providers. So we have a whole program that's actually being implemented in Muskogee right now, where we're using yellow cab transportation in a whole new form of transporting, scheduling patients and getting them to their appointments in Muskogee. Now on the other side of the house, we take this large data set that was donated
63
to
million
63
patient
million
records.
patients. And one of the other things that came out of the surveys, to your earlier point, is we lack specialists in rural markets. So if I'm a diabetic patient and I live in rural markets and I've got diabetic retinopathy or blindness from diabetes or diabetic nephropathy, which is kidney failure, there is no ophthalmologist, there is no nephrologist in rural Oklahoma to provide adequate care. So we've actually gone after an effort to develop predictive analytic tools, for instance, in diabetic complications, so that I can give those tools to primary care docs so they can manage diabetic complications with algorithmic based medicine in markets where they don't have those specialists.
So you've studied the patient records that had this problem. I mean, that went to a problem of blindness or kidney.
Yeah, so diabetic retinopathy.
Then you kind of can figure out what the markers are that
Absolutely.
are leading to that.
So in diabetic retinopathy, for instance, we had 2 million patients in our data set, which is why we can do some of this stuff. I mean, it is phenomenal that I've got a database of 2 million patients, of 2 million diabetics, that I've got their ophthalmic information. So now I can go back in time and develop tools to predict out of their lab data that's normally collected, their demographic data and their comorbidity data, to be able to predict whether or not they got diabetic retinopathy without them needing to go to an ophthalmologist.
And then when they do find that they are on that path, then they can go to an ophthalmologist.
Then they can be sent to an ophthalmologist.
Yeah.
And that's the power of both the data and the workfloor stuff we're doing.
Because people don't realize, I mean, if you're in rural Oklahoma or rural anywhere, you got to take time off your work. You're going to drive an hour or 2 hours. You're going to wait around for an appointment for who knows how long. And it's an all-day deal.
That's right.
And they just can't afford to do it.
And that's exactly right. For many rural citizens who are hourly employees, lost day wages, transportation costs, healthcare costs, they could literally be into an experience to go to Tulsa, Oklahoma City, Stillwater for an ophthalmic evaluation for diabetes. It could cost them $300. And that's a significant financial
But here, even a PA can look at this algorithm
Absolutely.
material. And
Yeah.
So, William, you actually go beyond innovation. You really go to implementation.
If I didn't have a network to actually implement our solutions in, then it really is for naught. I mean, it produces papers and PowerPoints and all that's really exciting and contributes to the academic knowledge, and we should do that. But we built a whole implementation network as well. I call it my implementation network, and it's 3 legs of an implementation stool. We provide care to 25,000 Medicaid patients through a contract with the Healthcare Authority. So I've got direct access.
How do you do that?
So we have a group of care managers that sit in the back of our office. They're nurses, licensed clinical social workers, and they take these 25,000 patients and provide care and case management services to these patients to make sure that they get to their doctor's appointment, that they get their medications filled, that they get to the subspecialist. They're really providing a lot of the hand-holding to get those patients through the system. So that's one leg of my implementation.
And are you finding that that's helped? I mean,
Oh, no question.
People actually respond to that?
We just completed this analysis, and we are saving, and this is hard costs, not soft costs that you kind of have to wave your hands. We are saving direct hard costs of emergency room visits that we avoid, about $500,000 a month. So about
Wow.
$6 million a year to the state of Oklahoma, which based on the ROI is about a 6x ROI for the state of Oklahoma for this case, on direct cost of avoiding patients going to the emergency room.
And that's really, the hospitals are eating that.
Absolutely,
If they-
yeah. And in our case, the Medicaid, the taxpayers
Yeah.
of Oklahoma. So one leg of the implementation stool is focused on patients. We've also built a whole clinic of rural clinic network. So we have a network of rural clinics that we test and implement our innovations in, and we have a whole network of rural hospitals. So now I have a patient channel, a clinic channel, and a hospital channel to actually implement my innovations.
Is the center involved in this ECHO program?
Sure, we view ECHO as one of the many solutions that are being deployed into rural healthcare to improve the delivery of
For
rural
our
healthcare.
viewers, you can probably summarize what ECHO's program is.
Yeah,
better
so
than I.
ECHO is a program that was brought to Oklahoma by Dr. Casey Schramm. It was originally developed in New Mexico, originally targeted on hepatitis C. We're using it for
In rural areas.
In rural areas, yes. We're using it for diabetes, using it for mental health. Basically what we do is we provide education services to rural providers.
You're kind of coaching them up.
Absolutely.
In these areas.
Yeah, so we provide the best in breed kind of urban medical capabilities through this channel of ECHO to educate rural providers.
And as I understand it, it's not a one-off deal. I mean, you're in constant contact and there's constant collaboration.
So we are an innovation center. We're not an academic department, we're an innovation center. But we do get involved in two aspects of education, okay? The first is in health data analytics. I really believe we can make Oklahoma, if you've heard my TED Talk, I really believe we can make Oklahoma the Silicon Valley of health data analytics, because we've got a data set right now that nobody has. It's a gold mine. But the big pacing item for me to do that is capable health data analysts. So people who really understand how to analyze healthcare data. It's a brand new industry.
Right.
So we have this whole methodical program that goes all the way back to STEM in the middle school and high school, where I'll provide any teacher in Oklahoma a cleaned up data set, protocols, and a video for how to put all their students through a health data analytics program in our high schools and middle schools in
Kind
Oklahoma.
of like learning coding when you're in
Absolutely.
school.
So bring them through, and then within Oklahoma State, we launched the Healthcare Analytics and Informatics Certificate Program. So hopefully when they graduate high school, they'll come to our university and go to our certificate programs.
They can pronounce it, they're pretty good.
Absolutely, in analytics and certificate. And then lastly, we just launched the Predict for America program that I told you about earlier, which is modeled after Teach for America, where we're bringing some of the best and brightest health analysts to Oklahoma to do a 2-year fellowship. So I'm really looking methodically at that whole health analytics education continuum.
And the Kaiser Family Foundation helped
Yes,
fund that.
the George Kaiser Family Foundation helped fund our Predict for America program. And then the second thing that we get involved in education is, if you think about how we're graduating doctors, they're getting ready to embark in a world where they're going to be hit with 3D printing, algorithmic-based medicine, digitized electronic medical record systems, mobile health, smartphone health, telemedicine, ECHO, all these things where innovation is impacting the delivery of healthcare. So we launched a series of programs in our medical school to train our students in medical innovation to augment their traditional medical education they get through their program. We do that through a program called Innovation in Medical Education, Engineering, Entrepreneurship, and Design. And so these students get exposed to 3D printing, rapid prototyping, algorithmic-based medicine, mobile health, telehealth, et cetera.
So you actually have a 3D printer here that you're using in this area.
Yeah, among many things we're doing as far as adding technology into healthcare, we have a 3D printer back there where you're actually able to, in this case, we're actually running a 3D printing program right now. And it's actually the vasculature of a brain of a patient that suffered an aneurysm. So you'll see the entire vasculature of the brain, and then you'll actually see a nodule in there where the actual aneurysm happened for this patient. Unfortunately, the patient passed away, but it shows you where the actual aneurysm. Why do we care about that? It allows a physician to actually be able to get an image in real time of what that patient's actual vasculature looks like prior to an actual procedure, so they know exactly where they're going to perform the intervention. So we do all that within the Center for Health Systems Innovation, and all really dates back to Neil's initial vision that he put for the center, that we were really focused on how do we actually transform healthcare. And we took that niche and went after rural healthcare, and we're going after it in a very heavy way to both deliver solutions in rural healthcare and increase the competencies of our state, both on education and analytics and then innovation.
Just fascinating. I think everybody can tell how important this is for our state and for the nation and the world for that matter. Well, that's another edition of Inside OSU. Here physically, we are at the corner of Cincinnati and 8th Street in Tulsa, Oklahoma. But in here, we're at the corner of innovation and implementation.